para que no quede como caidito, como que está ahí abajo.
Ahí.
Ahí está
Mejor.
mejor. Sí.
Sí.
Yo de atrevida, discúlpeme, pero
Oh,
va a ser mejor.
Y
perfecto.
ahora vamos a estar ya todos con posibilidad de video. Listo. Bueno, entonces, haciendo uso de la puntualidad que hemos tenido en el desarrollo de esta semana de la propiedad intelectual, interés público y COVID-19, vamos a dar inicio al panel, que es el panel principal del eje temático de acceso a medicamentos. Voy a permitirme entonces hacer una breve
Vou
presentación.
fazer uma breve apresentação dos nossos palestrantes que nos acompanham hoje.
Of the panelists that are going to be with us today. And then I'm going to try to explain a little bit the dynamics. I want to introduce myself. I'm Angela Costa, current director of the Misión Salud Foundation in Colombia. And it is an honor for us as an organization which has been the summoning of this event to have all of you here in this panel. We are very pleased to share with you these reflections and to have this exchange space, because we believe that from our
tenemos mucho por aportar y no solamente pues entendernos como una región de América Latina,
a region of Latin America, but also get to know the perspectives that we may have the possibility to recognize in the participation of one of the panelists from the United States. And some have a meeting that is a little bit more global. So I'm going to share here the screen with them, all my colleagues, to introduce them formally. Our main panel for drug access has been named Access to Treatment and Vaccine Alternatives for COVID. What do we do with the patents? This is going to be the main question that our panelists are going to answer during their presentations. So we have the pleasure of having the participation of Dr. Alvin Chavez Matamoros, who is a surgeon from the University of Costa Rica, a specialist in internal medicine of that university, and also a specialist in clinic pharmacology with studies at the Pharmacological Research Institute Mario Negri from Milano, Italy, Master in Pharmacoepidemiology of the Autonomous University of Barcelona, and resident of the Information Division of Drugs of the Pharmacopoeia of the United States. And for many years, he has been a point of reference in everything having to do with our topics regarding drugs, pharmacotherapies, and access to drugs. Dr. Alvin is with us today, and we have to make a clarification here. It's not an official presentation of the government of Costa Rica and the position and the initiative they've had recently with regards to these moments of pandemics, but rather he's with us from his own perspective as a person that is knowledgeable of the access to medications of that perspective, and he's going to share some opinions from this point of view of the different initiatives that seek to favor the equitable access to treatments and vaccines right now that we have a global emergency. Welcome, Dr. Albin. We have with us also Peter Mayberduk, who is a leader of a knowledge economy and access to public citizen medications, helping partners from over the world to secure benefits of science and technology for all. The work of his group has given shape to the legislation and the executive action so that medication can be accessible, and he has changed the course of trade negotiations to protect health and digital rights. Today, Mayberg and his colleagues are working to improve response to COVID-19 pandemic and prevent a vaccine of the global apartheid. Welcome, Peter. And we also have with us Lorena Di Giano, a lawyer specialist in human rights, access to medications and intellectual property, executive director of the Foundation Grupo Efecto Positivo, general coordinator of the REDLAM for medication access, member of the advisor group of panel of experts of the top level of the United Nations about access to medications and innovations. So, together with these three great guests that we have, we are going to develop the main question of our panel regarding these initiatives or reflections that we have today to share around the different alternatives on vaccines that are being explored for the management of COVID-19. Within these alternatives, what is it that we're going to do regarding patents and IP? The time that you will have is maximum 30 minutes. I'm going to have a control mechanism in my hands, and we hope to have 15 minutes at the end for open discussion for those who are participating in the panel. And invite you that if the discussion extends beyond the time, we have foreseen a link in Telegram where we can continue with this discussion and idea exchange. So I am giving you the room now so that Dr. Albin now will begin this session of the panel. Welcome, Dr. Albin. Good morning. First of all, I want to thank you. Countries. I'm going to give you the basic Africa is so concerned and why it has always been of its interest this topic about patents and intellectual property issues.
Cuidado da saúde.
It's a constitutional right, and we have to have this clear. In order to comply with this, we have developed a health system where the general coordination is from the Ministry of Health. And then we also have the public sector and the private sector included therein. The public sector as an institution that plays the large responsibility is the Social Security of Costa Rica, and in the private sector, we have the resolution and the participation in health, which is quite limited. So in other words, public sector plays a transcendental role in complying with the right for healthcare. The Costa Rica Caja de Seguro Social is the institution that is going to play the most important role in care, in healthcare. This was created 78 years ago. And it is important to say that the law that provided life to this Caja is a constitutional law. And for the last 78 years, the financing mechanism for social health care was created. This is a tripartite financing financed by the workers, by the employers, and the state. And it's a contribution as partners ruled under philosophical principles, which I consider that are important for this topic that we're discussing, the topic of universality and equity and solidarity, mandatory and Social Security is responsible for prevention, curing, and rehabilitation of the inhabitants of Costa Rica. Another fundamental fact that Costa Rica has is that in 1982,
aquí esto es un hecho muy importante en donde la selección del producto se origina con base a las necesidades
em relação às
epidemiológicas
necessidades
del país y esto se complementa con criterios clínico-farmacológicos y la sostenibilidad del sistema. Y aquí es un hecho que quiero resaltar que los criterios clínico-farmacológicos son los que van a determinar con base a la medicina basada
based on medicine, based on evidence, is based on a technology that is a therapeutical innovation. So, in this panorama established in our country, we have established the essential medication policy, the concept of generic medications, which plays, or this is a fundamental concept in order to be able to assure access to medications. This health system that we have brought forward and strengthened throughout the years has allowed us to have results that are very satisfactory in the medical environment, the social environment, and the economic environment. And this is evidenced because our country has a general mortality that is very low, 46 every 9,000, considering all the different chronic and degenerative diseases which have a great prevalence. Children mortality of 7.8 for every life born, every 1,000 life born, and maternal mortality that is very low also, and a life expectancy which is around 80 years of age today. If we look at this from the point of view of the medications with this policy of essential drugs, access to drugs stands around 95% of the population. And this is clearly evidenced that every hospital every external consultation receives 5 medications, and every consultation for emergency services includes about 2 to 3 drugs. So this is achieved from the economic point of view with an allocation or with an expenditure of 7.5% of the expense in health. So this achievement in the access to medications for many years because we cannot leave aside the capacity of pharmaceutical companies to charge high prices, although the drugs from the clinical and pharmacological point of view gave benefits to the patients. And it also fosters great part of the investigation that leads or takes the patients that are suffering of certain pathologies, for example, cancer. This works on the insurance companies, forcing them to make high investments regarding what the company is recharging. There are many examples on what intellectual property means in access to medications. So in treatment of cancer, and they have determined therapeutical assistance. A few years ago, the annual treatment cost for patients in our country for a public health system reached the amount of $26,500. Once we have the intellectual property for these medications, the cost was $1,500. So what does this mean? What this means is that it improves access to medications of the population. So what I said at the very beginning, this is an element that has permeated the Costa Rican population and the citizens in Costa Rica, and it is considered that the right to access to health, as the right to access to drugs, is a human right. And all the governments have strengthened social security so that it makes efforts to continue assuring access to medications and also provide sustainability to the system. So this explains the reason for which the current government, facing this threat that all the countries are facing with this pandemic, will present the initiative of calling solidarity in action. I must point out that Costa Rica, through its president, Mr. Carlos Alvarado, and the Minister of Health, Mr. Daniel Salas, proposed to the General Director of the WHO, Dr. Pedro Salanon, to facilitate access and use of intellectual property of technologies in order to detect, prevent, control, and treat COVID-19 pandemics. This is where the initiative of calling for solidarity comes from. Solidarity for action to create a repository of knowledge that can be shared, where intellectual property and data would be used as a collective effort in order to promote science, development, technological development, and a broad exchange of benefits of scientific progress and applications based on the right to health. In order to elaborate this proposal, we created a working committee, an interinstitutional and interdisciplinary, with the participation of officers of the Ministry of Health, of the Social Security, Foreign Relations Ministry, and the OPS. And the base proposal had 11 clauses, amongst others, included important considerations in order to secure access to knowledge, intellectual property, testing data, research data, and technological transfers for all the countries. The launching event of these initiatives happened on May 15th with the participation of Mr. Carlos Alvarado, President of Costa Rica, and Dr. Pedro Sadanov, General Director of the WHO, Mrs. Mia Montlake, Minister of Barbados, Mr. Abstis Jacobson, State Secretary of Norway, and they gave speeches through video conference. We had Mr. Lenin Moreno, the President of Ecuador, Mr. Thomas Examos, President of Palau, Mrs. Machalev, High Commissioner of United Nations for Human Rights, Dr. Hayan Chapagayo, General Secretary of the International Federation of Red Cross and Half Red Moon Association, and Mrs. Leva Masoon, the Ministry of Foreign Trade in Indonesia. The university, world, industry, and civil society also participated in these debates. The participation in the pooled access to economies to technologies in 2019 is based on social solidarity. The initiative works as a window, as a single window that will allow to distribute in an equitable manner the knowledge, the information, and intellectual property rights of the scientific world amongst the world community. At present, 40 countries, members of the WHO, have reported the WHO and or the government of Costa Rica that they are also joining that call of solidarity action Of these, 12 of these countries are in Latin American. The effort that should be made is one of the fundamental premises of investigation. And in this specific case where we're talking about COVID-19, it should expose therapeutical technologies, curative technologies, or preventive technologies that will represent benefits to the fight against this pathology that is affecting the entire world population and affecting all, or is providing big problems to all the countries, health problems, social problems, and labor problems. So this is why we in Costa Rica, we have started research which has a social component that is essential. Therefore, one of the elements that are clear to us is that we must avoid that these therapeutical innovations, once they are available and when they enter the market, do not have prices that are not affordable for most of the countries. So this is why this is a fundamental fact that if there are new alternatives for treatment and for vaccines for COVID-19, these products, if they really do represent a true benefit for the population, we must be aware of the objectives. The most important objectives of the healthcare systems is to protect life and health, defend human rights, preserve social equity. This is why they should be considered as public assets, global public assets, and therefore we are fully convinced that there should be no intellectual property rights on them because the common should prevail on the individual well-being. I think you should have this very clear, and Costa Rica joins with its philosophical principles of equity as an extension worldwide, thinking that the most important element in any health system are patients. Thank you very much. Thank you very much, Dr. Albin. Your talk has been very illustrative and the basic fundaments of your proposal from Costa Rica, which, as you already said, has been adopted by the WHO. We will later on have an exchange of ideas of how there have been other steps to move forward and what is it that we can recognize of this initial proposal of what has become the initiative as the gold initiative. Now we're going to give the floor to Peter Myberduk. Thank you for being in the panel, Peter. Thank you, Anela. Thank you, everyone. Good morning.
English so I can better present the technical picture. I offered to speak in Spanglish and was told not to butcher the language. So I will offer my comments in English as slowly as I can, and let me know if I should.
Vamos a ver si funciona.
As was mentioned, I work for Public Citizen. We are a consumer group.
Nós somos grupo consumidor.
And we have been working with colleagues around the world these past 15 years as part of the Global Access to Medicines movement. Today, if anything, I believe that media and public reports have underestimated the problem, or the scale of the challenges and the humanitarian consequences coming that we face. No corporation manufactures at scale to supply the entire world. We have seen that this is true for masks, for ventilators, for oxygen. We have documented here at Public Citizen shortages of remdesivir in the United States, the country that had best access to the first experimental drug against coronavirus, remdesivir, Gilead's remdesivir. Even though the United States bought its way to the front of the line, nevertheless, 38 hospitals in 32 cities in 12 states did not have enough remdesivir according to their medical criteria by which they wanted to dispense remdesivir. Shortages are everywhere and are going to be with us for the next several years. This is, of course, in part a problem of monopoly, as access to medicines activists know well. But we have to adjust our tactic and our analysis somewhat. Whereas for the past 20 years, we primarily have fought the problem of high prices, high monopoly prices. Today, our top challenge is a problem of limited supply. And of course, there too, if we can break the monopoly and introduce more producers, if we can share knowledge, share technology, if we can introduce public production of diagnostics, treatments, and vaccines, the world will have a better shot at supplying medicine to people who need it for the course of the pandemic. We were among 250 organizations from around the world that signed principles to this effect, which I will put into the chat when I have a moment. We have them in English and in Spanish, and would welcome your organizations signing on to put the word out to medical leaders around the world how we should be sharing technology through this time. Now, in the English language media, we often see the coming problem of vaccine access referred to as vaccine nationalism. Vaccine nationalism. From my point of view, that is actually an insufficient term. It masks the human consequence of what is coming. It talks about a geopolitical struggle. And frankly, if you sit in the United States, vaccine nationalism doesn't sound so bad. We can go toe to toe with Russia or China or Germany to a limited extent. There are, of course, significant problems there as well. But it's worse than that, right? I think all of us on this call know what's coming is worse than that. It is much more of a global vaccine apartheid. And by that word, I mean to invoke the example of South African racial segregation. Though in this case, of course, we are talking about discrimination, limitations, a divide in availability based on wealth, based on race, based on country. We will be divided into a world of wealthy nations and privileged citizens and a world of low and middle income countries that have to wait for a long period of time for access to a safe and effective vaccine. The head of the Serum Institute out of India, the world's largest vaccine manufacturer, said recently in an interview that looking at current vaccine production, and even with the hundreds of millions of dollars, well, many billions, the United States has put in 10 billion on its own investments in vaccine production today. Nevertheless, we are on course for a 4 to 5 year delay before most people in the world can access a vaccine. In other words, between the time when the first person gets access to a safe and effective vaccine and the last person, it could be 5 years. And if we think about the consequences of the pandemic, the past 6-8 months, 8+ months now, we understand we can imagine what the damage of many years would be. For one, we will lose a terrible number of lives, but also it's going to have devastating consequences for our economies. The most vulnerable communities will be affected the most, and it could have a significant consequence for political instability. So global vaccine apartheid. What do? We will have to resist. For one, of course, as we understand in social movements, we will have to resist and set an example of resistance, but we will also have to offer alternatives, a vision of hope and of possibility. So let's talk a little bit about what that looks like. I was asked to address the climate in the United States right now. One of the major challenges that we face, of course, is that people everywhere are scared of being left out. And we are going into a scarcity mindset. There is an understanding that rationing is here and rationing could get worse. So, for example, it is hard for American politicians to talk about giving any vaccine to anyone, anywhere, before every last person in the United States has received it. That is, of course, partly we see it in Donald Trump's terrible nationalism and racism, but it's also true of Democratic candidates. It's a difficult commitment for them to make, to contribute to COVAX, to contribute to the World Health Organization and the world supply, because of the sense that we are dividing up a small, limited pie. But of course, those of us on this call understand that while only you or I can take a single dose of a vaccine, if I take it, you can't have it, all the world can benefit from the underlying technology and knowledge without diminishing anyone else's enjoyment. In other words, all of us together can teach one another to make better vaccines, to make more vaccines, to make treatments, to make protective equipment. We can share the technology, we can license the patents or annul the patents. We can provide technical assistance to set up the facilities. We can share the large dossiers of confidential information and know-how, and we can expand the world's supply. It will take time. It is not without technical challenges. But if we start now to change the politics and to build factories and to install the right equipment in factories and to repurpose the existing facilities, then over the course of a year, 2 years, however long it may take, we will be able to expand the world's supply. And it's critically important because shortening the pandemic by even a few months for people around the world will save a great number of lives and mitigate the economic devastation that is coming. So we must do everything to increase production. And fortunately, in the United States and with countries around the world, we have the tools. Some of these, compulsory licensing from other access to medicines fights, also authorities to bring public production to bear. And as has been discussed, new global initiatives like the World Health Organization's Technology Access Pool and Costa Rica's proposal, which we think is critically important. It's important because it is a well-tailored mechanism to solve many of the pandemic problems, or at least mitigate those problems. And it is important because it is an official World Health Organization program that is up and running. And it gives us an example to point to when we talk to our governments and say, what do we want? What must we do? We can say, it's this over here. It's not only a discussion about how to ration better. It's a discussion about how to not have to ration so much, how to expand the pie, bake a bigger pie for all of humanity. Some considerations in the United States. We are coming up on an election, as you may have heard, in a few weeks, and it's an especially terrifying election. We're concerned about problems at the polls. We're concerned about the rule of law. We are very concerned and very embarrassed, frankly, about the state of our government and what it has done to the rest of the world, or what sort of example it sets for the rest of the world. So these are obviously very, very important times. I think analyzing the candidates' administrations, we understand that if the next US administration is also a Trump administration, there may be little that we can do to move the US government into a much more productive position. It simply will be difficult to get the United States to contribute meaningfully to the global response. We will do our best nevertheless. If the next government is a Democratic Party government, if it's Joe Biden's administration, it's not clear what that administration would stand for, but we certainly intend to set an example by which that administration could respond differently. working with opinion leaders, working with faith leaders, religious leaders, leaders in the foreign policy establishment. We intend to show how the United States can contribute to the World Health Organization, contribute to the technology access pool in the Costa Rica proposal, and also just use its separate tools under law to make patents and know-how available and contribute to the world's efforts to make vaccines, safe and effective vaccines, more quickly. There's obviously a lot to say about this, but I am proud to, can you still hear me? Can I get a thumbs up if you can still hear me? I have a speaker. Okay, sorry, I got a notification. Okay. I'm happy to announce today that on October 21st, we will be going into the streets. We will be launching a demonstration, a rally, where many organizations are going to come together and say, we demand a safe and effective vaccine, stop politicizing the science, and we demand that everyone everywhere in the world has timely access to that safe and effective vaccines. We are going to protest in Washington, D.C. with many of our colleagues and really begin to sound that alarm. That's October 21st. We're, of course, contributing to and very excited about the People's Vaccine Campaign led by Oxfam and UNAIDS and other organizations, calling for a vaccine that is available to everyone worldwide, no discrimination, free, and a public good that everyone can produce. And we find that example of the People's Vaccine Campaign very, very helpful. The United States is not thinking about global access today. We have to move it to a place where it does. And tomorrow is too late to begin, as it may be true for many countries where we are all still waiting to see what sorts of vaccines will be introduced, and very studiously and importantly, doing our best to understand their safety and efficacy profiles and ensure that our regulatory authorities maintain stringent standards of safety and efficacy and don't put a bad vaccine on the market that could limit faith in a vaccine and limit the number of people who take one and thereby extend the pandemic. But we also have to be thinking now about these production issues because tomorrow is too late, because it will take time to develop the equipment to increase supply and to make a people's vaccine all around the world. We invite and support and stand in solidarity with everyone in low and middle income countries who is raising a ruckus. There's got to be a demand. There's got to be protests. There have to be visible examples from around the world of people saying, we need access and we won't wait and we won't stand for vaccine apartheid. We won't stand to be treated as though we are less. We demand equal access, equitable treatment now, and we will support those calls. I will share our principles in the chat and I look forward to our discussions and questions. I think the last point I want to make is that, for many of us who have been with this access to medicines movement for a long time,
Está nesse movimento de acesso a medicamento por muito tempo.
Looking back to the prior pandemic, epidemic, global HIV/AIDS, we learned lessons for that, lessons that are important for the world, lessons that can make a difference today to confront the challenge of the pandemic. And so what we're trying to do today, and what we all need to rise up and be able to do together today, is not just to make a point about patents or use the pandemic to make our argument that the research and development system should be different. We need to contribute to the end of the pandemic. We are able to contribute to the end of the pandemic to save a great many lives and avert economic disaster. What we have learned about patents, that knowledge, what we have learned about fighting the pharmaceutical companies and sharing what we know is critically important to humanity today to mitigate the damage. We are working together to offer a path and to offer hope, and I'm so glad to be in it with all of you and look forward to your questions.
Peter, muchas gracias por
Peter,
esta.
thank you very much for this intervention, which leaves us with great reflection for what will be
antes de
One
este,
moment, estoy oyendo, se me está cruzando portugués.
es muy bueno
It is, no, no puedo traducir, se está oyendo a Hermes.
que
I'm
Hermes
not hearing, I'm having interference.
muy buena referencia de lo que ha sido la historia.
Sorry,
Muchas
tengo
organizaciones
interferencia.
de sociedad civil, tanto en Estados Unidos como en nuestros países de América Latina.
Sorry.
Mencionabas esta comparación de lo que puede ser la discriminación. Y no nos referimos a esa discriminación humana, sino esa discriminación en cuanto a riqueza, a países, a diferencias entre países, como esos principios que siempre han guiado a organizaciones de sociedad civil hoy son tan importantes.
The organizations of the civil society need to reincorporate and reivindicate
De urgencia, de
emergency and urgency. We need to have treatments and accessible vaccines, effective and safe ones. You also mentioned the steps that you anticipate for the future, for example, with treatments such as antiviral.
cómo
Além do tema de preços e as possíveis regulações aplicáveis,
también ustedes perciben
You also perceive a problem now as far as distribution. And how is it that the organizations can join so that these distribution can guarantee more equitable um, and pertinent scenarios at the time these treatments are approved for their use in this global emergency. Very interesting to acknowledge also the reading you share uh, from the country, from the United States, as far as the political situation, which from here in our countries we also see in its complexity and what these political decisions have been relate to something that might be not sufficient, nationalism, and see how these political guidelines or directives are already establishing differences and possible inequalities vis-a-vis these treatments and possible vaccines. Very important also is the news you are sharing regarding the demonstration on October 31st. I know from our organizations, we will be supporting you all. Hopefully, you can organize many more because at this point, as you said, it's not enough or sufficient to have one or two organizations with these initiatives. It is worth, following this other principle that you mentioned, which is to have everyone join together at this point where it is needed so much from us as far as social responsibility in order to be able to reduce these impact that we were seeing socially and economically in this time that we're experiencing. Thank you very much, Peter. And with this, I will open the floor to Lorena. Give the floor to Lorena. I think we don't require any additional reflection regarding her vast and ample experience and her active participation in what Peter was referring to as all the reivindications related to access to medication.
muy bien que después de esta buena,
I think it would be great to have you next after all the ideas Peter gave with this purpose of the different countries in Latin America as far as having access, equal access to vaccines. You are not restricted. I mean, you have all the time in the world because we've been following the agenda strictly. Thank you very much, Angela. Thank you, Global Congress, for having invited us to this presentation. I I'm not that, I mean, I tend not to be so brief. But this question that summons us today, what to do with our patents within this framework of a pandemic of the COVID-19, has raised a series of questions that we, as Peter was saying, have been observing and working on. In this presentation, I, as executive director of the HEP Foundation, I am going to introduce this GEP Foundation. It's a group of people with VIH who decided to organize or establish this organization in 2006 in order to defend precisely the rights of the people affected. That will be the interest that I will represent in this presentation. Foundation HEP also works in collaboration South-South on what we call the Red LAM, Latin American Network for Access to Medication, integrated by or composed by Avia, people from Brazil, Foundation HEP from Argentina, Acción Internacional para la Salud from Peru, and Foundation ePharma in Colombia. So we work jointly in an articulated manner on the barriers of intellectual property to have access to medication. So in the presentation, I am going to refer to the system briefly, and then we will proceed to share what we've done, we as the people affected and the civil society, what we've done to intervene in this system which deprives us from access to medication and or continuity of treatment. Many of us are people who suffer a chronic disease. That's how the market determines us or defines us. We need to have access to treatment every day. We need to ensure continuity and sustainability of the programs, of the treatment programs. And finally, to make some reflections regarding the system as the prior lecturers have mentioned. This is the model of innovation, the system of patents adopted within the framework of the World Trade Organization, what we call the ADTRIPS agreement in the 90s after a global campaign. So what was handled then, if we make an incentive for investment by the private sector in access to technologies, we're going to have more answers and solutions to health problems. And the minimum protection standards were globalized for all areas of technology. And this meant or means inclusion of the inclusion of medical technologies implies for many of the developing countries to start acknowledging we had a binding agreement. We started to recognize, we had to recognize intellectual property, which did not exist in our legal figures. So as I was saying, the members of the World Trade Organization obligate or force make it mandatory to adopt these measures in all territories. So what did this bring? Proliferation of requests for pharmaceutical patents, foreign pharmaceutical patents in the countries in development or developing countries. So what did this patent system brought or generated? Exclusive rights. The title holders of a patent or medical technology can exclude others from fabricating, using, selling, or importing the patented products. That is, what this system determines is not no competitors. You can no have competitors in this market unless the title holder of the patent allows so. And for a minimum of 20 years, and we write their minimum because we, in practice, by observing the conduct of the pharmaceutical companies, is that we see that they request reiterated patents to keep with the to maintain the monopoly for more than 20 years. So they create monopolies, exclusive nature in these services, and the title holders can establish high prices, and in some cases excessively high prices. Sometimes it's incredible to see what it costs to treat cancer, or for example, the face masks in the, $24,000 for the treatment of one person. It's outrageous. So within the system, we not only have the protection, and this is something that Peter referred to before, and it is what we call the health safeguards. They normally are also found as flexibilities in trips or at these safeguards are part of the system, and they allow to guarantee health in those cases where the governments need to guarantee health to their population. We like to make this differentiation or distinction within the set of safeguards, and we like to divide it into two groups. We refer to the preventive nature ones, or preventive type of safeguards, and the repairing safeguards. At the office, they said in 2012 that 90% of the requests for patents received at the office in Argentina do not comply with the standards of aid. They're not new, they don't have application within the industry. So what do we do with patents? What do we do with the requests? And the truth is, within the safeguards, we think that the ones we call preventive type of patents, it's important for the offices to examine these types of requests. It's not good, especially to exercise the right to health. It's not right for patent offices to assume that a request, meets the requirements. Many times they just grant them without making an exam or a test. Another important aspect is the criteria, rigorous criteria of patents. In Argentina in 2012, they adopted a law to accept what is acceptable and what is not. To decide that. So when countries make use of these safeguards, many times they receiving negative consequences because the uh, multinationals, pharmaceutical multinationals, are requesting the government to annul these and reject patents which do not comply with the requirements. Another factor is the observations by third parties and oppositions. It should be part of this instrument should be part of the national law for patents. In Argentina, we have it, and I'm going to tell you how we use this mechanism. So far, we're seeing or looking at what can be done to prevent. But we have another group, and it's when you already need to repair. So we started with the preventive ones, and when we already grant one, or when one is already granted, we have the obligatory licenses. Peter mentioned the possibility of an executive power or branch in a country to allow the production of generic drugs, and then no one loses. We can have fabrication, competition, and everyone benefits from the payment of royalties. Of course, the obligatory license will finish off the monopolies, and that's what they don't want. Countries, when they try to use this type of instruments, suffer all types of negative consequences. There are a few cases, but there are some around the world of the use of these licenses. So let's go and proceed to allow me to tell you how we've intervened by using these safeguards, because as Peter said it, we need to guarantee access, and we need to, in our mission, to contribute to access to medication. So the national law of patents that we have to adopt as Argentina, we adopted this law 2481, which as of 2000 forces us to recognize patents. Article 28 allows the opposition of third parties, which is about collaborating with the analysis of a request and contributing tests, evidence that a patent, for example, doesn't meet the requirements. So these are some of the examples that I brought to share with you in the table. Some of the work against or opposition to patents. These are medications for HIV or for hepatitis C. But I want you to focus on the last one, on the last column, which is the one referring to savings. So far, we were able to measure through our observatory lab what had happened. We, okay, what are we seeking? We're seeking to have competition within the market. For example, in the case of a very much used combination today, it took some years, but tenofovir tifavinase is from the Gilead pharmaceutical company between 2015 and 2017. In Argentina, the Ministry of Health of the nation was able to save $118 million because the patent was rejected, because at that point we didn't have any monopoly and we were able to buy or purchase the medication. And we're talking about lots of money for a country like Argentina. And it's very important today as far as treatment, the tenofovir from 2016. Between 2016 and 2017, thanks to the entry of a generic local product, we were able to save $28 million. We've I'm not going to refer to all of them. It was just for you to see some examples of what we're doing and how we intervene with the system and what our achievements have been. So the pandemic arrived a few months ago, as the other presenters mentioned it, and we as an organization, in order to see how we could contribute, we started in March, I think, to analyze the technologies that started to be tested in order to have some way of dealing with COVID. So there were some medications that already existed in the market being used for some other diseases. And we saw that some were used for Ebola or some other type of coronavirus. And the most promising one, with the one that was more promising, we said, okay, let's analyze remdesivir. And we started seeing that it showed some kind of effectiveness, not in full, and it wasn't the solution, but for some cases of, very ill patients, it was helping a lot. And we started a registration to see a registration of emergency by the European Union, making a registration, some others, some other registrations in Singapore and other countries. We started seeing and analyzing that Chile has patents in more than 70 countries around the world. We looked at Argentina and we see that we submitted 7 requests for patents, all for remdesivir. We also were able to see that the company Gilead signed a voluntary license with 5 producers in India and Pakistan for generic production to make it accessible. But clearly, when we analyzed this license, it excludes Argentina and all these South American countries. And this is a problem because then what are we to do with all these licenses and patents that are not excluded? And another variable that we had to analyze is something that Peter referred to priorly, and it was nationalism. The United States and many countries in Europe bought all the doses, the existing dosage for the next few months. So what to do? On the other hand, we saw publications by the University of Liverpool analyzing the medication and the costs of production. So they said to produce treatment for a person of remdesivir, you can do it at a cost of $6. That was like the cost of production that we had as reference. So the different versions started to come. Chilean, 2,340 for one person. Then we started seeing the versions of voluntary license. We cannot afford it, but it's just for you to take a look at it. $400, $224 per person. So we said, okay, what are we to do? We started extracting copies from the Office of Patents and the requests she has submitted. And we started analyzing them and we started looking at the requirements of the law. For example, in the first one, so far mm, we opposed to three of the requests, and what we were able to see is that truly they reivindicate methods of treatment, and this is a scandal. How can the company, knowing that the law doesn't allow this type of patents, and if it passes, it is approved. But in all cases that we've analyzed, and we're already working on three more, we were able to see that the requirements were not being met.
Ningún paso significativo en la ciencia, es decir, era obvio para un técnico en la materia. Y empezamos a hablar también porque nosotros en Argentina tenemos mucha capacidad de producción local. Tenemos un sistema privado de industria farmacéutica, el sector privado, que es muy, muy fuerte. Entonces comenzamos a hablar y bueno, empezaron interés de fabricar el remdesivir, pero bueno, el problema digamos, aparecía era en este tema de las patentes, ¿no? Porque Chile ya tiene una patente otorgada en Argentina. Con esa patente y otras 6 pendientes de resolución, realmente es una situación y que empezamos a trabajar. Bueno,
this is something that we started to work. We have not finished this work yet, but we are trying to bring these barriers away from this monopoly of Chile, that on the Argentinian industry we can manufacture at prices, maybe not the prices that they have in Pakistan, but better prices than Chile, assuring this availability in the country, but also as a source for the region in Latin America. And of course, we've asked the patent office to reject the patent. We have also made progress, as I said before. We have been working on treatment through this logic of chronic treatment. This issue about vaccines is something new for us, but we are trying to move forward and analyze how things are. And we were able to find a source of 188 patents that are directly associated with vaccines that have been studied and tested and gave a proven immune response. It's a matter of thinking that patents have nothing to do with vaccines, but this is wrong. So you can see here the distribution of biological patents associated with SARS and MERS. And you see here that about 60% of the patents that we have on biologics have to do with vaccines. So we here see the issue that patent topic on vaccines for COVID is going to be a problem. So we started to see what were the requests. We know that there are several vaccines that are already advanced in their studies in phase 3 or 2. And here I have some information on 3 vaccines that are the most famous ones. The Moderna vaccine, mRNA, I would say that there are international requests for international patents, but in Argentina, Moderna already had 3 requests of patents on this vaccine. The Oxford University also has patents and Pfizer also. But something else that I wanted to show you is the difference of prices that we have been discussing, the way this has been commercialized. Moderna, from its logic and the use of the patent system that pretends or has a monopoly in Argentina, they said that they were going to charge between $32 to $37. And on the other hand, the University of Oxford, AstraZeneca, is very peculiar here because there is an announcement made by the president of Argentina together with the president of Mexico, where they say that they got to an agreement with AstraZeneca, which is the company that has a license for this vaccine of Oxford. And they got to an agreement for technology transfer with the idea that the active principle can be prepared in Argentina, completed in Mexico. And this is going to be a source because this is a vaccine that will show effectiveness, and that will be a source for the entire region, except for Brazil that had a different agreement with the company. So this is important. I saw reactions also internationally saying, okay, what do we do with this issue about access to these technologies that we need for COVID? And the truth is that having the possibility of nationalism, that we don't have the capacity at a world level, we can use the production capacity that we have installed in Argentina for a vaccine that can be provided for the entire region. And we think it is very important. But we also said that this agreement it was not a non-profit medication. It was only going to cost about $2 to $3 the dose. So what did we get out of 26 years of the implementation of this patent system? As I said, monopolies on essential medications with extortive prices. The promise that there was going to be more innovation and more molecules and more responses to these health problems, we have not been able to achieve these. We have scarce innovation. Most of the requests that are patented are just incremental developments about this is very little. We don't have true innovation. And the abuse of the patent system by the pharmaceutical industry. In the case of Sapolvir, this central treatment for hepatitis C, we found 14 different patents on Sapolvir, patent requests by the company. So there is an attempt of repatenting or having patents on combinations or making small changes in formulations and start requesting successive patents to extend the monopoly for more than 20 years. Then we have unattended diseases. Since this is based on the market and the market or whatever the market wants to invest, they are things that they are not interested in investing in diseases in the poorest zones, for example, what there is no market or no profitability secured. On the other hand, we also see that pharmaceutical companies or laboratories, pharmaceutical companies started to become companies that are no longer dedicated in the laboratory to find a solution to the health problem, but they are trading in the market and like where, like the shares in Chile, for example, in the New York stock market, and these prices of these is very speculative, and the market is defining priorities in health based on profitability, and the state should play a role. I also want to talk in this analysis of the system and all these matters that we see that have been happening a long time, and to see if the system has been working or not. And I wanted to show you this recommendation of chapter 6 of a high-level commission of the United Nations, which is the commission of the law, which analyze different aspects of the anti-AIDS law, which is the access to medications. And this contradiction that I was presenting before are within the recommendations. And this is what the Commission said. The Commission said, recommends the member states of the MCT to stop the ADPIC that are related with essential pharmaceutical products because of the monopolies, high prices, and because of the technology that is only for interest for the market. And this is the status quo, but they are also negotiating the APEC Plus measures with in pharmaceutical patents. It means extending the terms or having some exclusions, as we have already mentioned. So the Commission also says that there should be a global moratorium, including any clause of intellectual property, any international treaty that is negotiated. So what we say, or our in Redlam we had a lot, or we have had a lot of discussion when the COVID pandemics arrives and places on the table this matter of the barriers that are generated for the vaccines. And in 26 years, the patent system is enough now. So we ask ourselves, should we continue acknowledging exclusive rights on these medical technologies? We have made some analysis and we have launched a declaration that is on our webpage. And you also have the possibility to sign there, put your signature there. And we're having a proposal that goes beyond the proposals that we have been listening. We thank the initiative that the President of Costa Rica had and that Dr. Alban presented to us. We think it is a role to focus the role of the World Health Organization on this framework. But as we said here, all the systems that are proposed in this framework are voluntary systems. So we say voluntary for whom? And the answer is for the companies. So do you think that companies that have been behaving and abusing of the system the way I described, and country by country and product by country, we are working with the healthcare system, we have not been able to solve. And they continue to show their monopoly, and they continue to exercise pressure on the states. This is very complicated for us in Argentina now, because there was a sanction to request from the pharmaceutical industry, multinational. The government sent a law to the Congress where they are given more benefits because they are approving a jurisdiction and patrimony equity in case they have damages because of the vaccines. This started in Europe, but we see that the companies are exerting pressure to be judged better than they are at a low cost. Our question is, what is going to be the result of all this? They're not going to be relaxed. All those rigorous criteria for clinical assays, aren't we urged to give an answer to these epidemics or to respond to the epidemics? We are being more lax, when the system is oppressing us. So we think that this started in the World Trade Organization and ADPIC, and this is all about public assets, not and social assets. This is not merchandised. So we believe that the governments have to go back to the framework of the WTO and work in favor of the market. Now, to finish, and in the same line of thought, I want to refer to something that I think is very important and that is working in the direction that we are proposing with our declaration. On the 1st of October, after many discussions and efforts made by the government of South Africa and India in the ADPIC Council for the compliance of this agreement, where the countries sit down to discuss, they presented a request to the members of the WTO so that they agree to waiver some of the obligations of protection and application and observance of the intellectual property rights, not only patents that are affecting what is happening right now. We believe that this is a courage from India and South Africa to be the leaders of this process. They're very brave. And there is only solidarity left for them because in the regions we have been discussing with the governments and we have stating that we have to get these technologies out of ADPIC, and they say, no, there can be uh, problems. No, they are working on the expenditure here, India and South Africa, and they're being exposed because they're not only representing what I think is the people of India and South Africa, but they're representing all the people in the world, all the countries that we are suffering under this system. So we need solidarity. If they have to analyze what to do, as Médicos Sin Fronteras has done and the South Center has done also, we encourage all the members of the WTO to support the proposal in the ADPICS Council in 10 and on October 10th and level of 2020 in order to adopt this decision. And with this, I finish. I want to refer to a sentence that has become famous amongst us of Dr. Luis Guillermo Restrepo from Colombia. He said, we will one day remember the patent with the same moral condemnation as we have remembered slavery today. Lorena, thank you very much. I am very happy to know that we have enough time for your development, which goes beyond a broad experience as the one that you have in Efecto Positivo group, which includes some very good proposals and timely proposals from a more regional environment of that effort that all these civil society organizations have been making in our countries in Latin America. So I am going to very briefly collect all the different items that have been mentioned in this participation of Lorena, so that added to the previous ones from Peter and Alvin, we can start having a conversation or we can start exchanging possibilities. As Lorena says, we're in a moment beyond the perspectives and beyond the efforts, which have been enough in more than 2 markets, and we need to take action. Lorena was saying at the beginning that it is very important to say that countries like Argentina adopted in the last decade the drug patent guidelines, which required a technical and academic effort that was important and were recognized in global entities like the WHO. But few countries at the end decided to incorporate in their schemes for drug patent evaluation. So this is a clear example of what this political decision meant. Lorena was mentioning also everything that this review made by her group, all the revision done by the group, and this is what we are discussing this week. And she was showing to us clear data about the licenses granted by GL, the laboratory that is one of the main laboratories of remdesivir, excluding Argentina and other countries in Latin America, and also how the foundation has moved forward to request the rejection of that patent or those possible patents that are in the process of evaluation in Argentina. And with regards to vaccines, it is interesting to see Lorena's reflection where she says that it is necessary to look at this topic of vaccines as we had been doing with the medications. I now from Mission Salud here, I share what Lorena was telling us. We have to see what is happening with the vaccines because it's not different to what has happened with interventions with medications. Maybe it is a little bit more complex. And the civil society networks have stated their concerns about the initiatives that are supported by Gavi Alliance and the initiative that comes from Europe, well known as COVID. At the end of Lorena's intervention, it is interesting to recognize the effort that is summoning certain different civil society groups which are asking for this proposal of solidarity and concrete action vis-a-vis the Congress that is going to take place on the 10th and 12th of October of APEX. So those reflections are the ones that we should use today more often or in this time that we have for exchange because they converge with the principles that Peter was sharing with us in his presentation, having to do with the summation of efforts and solidarity. I won't take more time. Now I would like to check possible questions or reflections that we would like to share in the participants that we have here in the panel now. Anyone who would like to participate, you can.
Nuestro máster se encargará de habilitar el micrófono.
Hi,
Veo que hay algunas. Sí.
Okay. So I want to thank.
¿Me escuchan? Bueno, yo quiero agradecer a Peter y a los demás participantes y a los que están escuchando, primero que todo por el trabajo que están haciendo, pero al mismo tiempo también pienso que la política no están a la par con la urgencia, con el problema y el problema que tenemos de vida o muerte de millones de personas. Esto se va a ser resuelto pues por una buena razón, pero especialmente con respecto a las vacunas, es compartir ese know-how para estas fábricas. AstraZeneca y Glaxo y otros han anunciado el compartir su know-how una vez esté lista la vacuna, pero otras compañías no. Lo que tenemos que hacer es una vergüenza para los ejecutivos de esas compañías que compran propaganda en la televisión en sus jurisdicciones, diciendo que ellos van a vender esto por eBay. Y en algunos países también les no van a tener vacuna por el nacionalismo de las vacunas y por esos contratos de precompra. Tienen que cambiar esto, porque si no van a afectar las economías de otros países, si no pueden cambiar sus posiciones. Nuevamente, esto no es una política de la que debemos hablar nosotros de qué podemos hacer por nosotros. Estamos hablando de una cosa que nos está amenazando y que tenemos que tratar esto como un problema muy grave y que tomar todas las medidas que se requieran que puedan inducir un cambio en esos países que no han mostrado una voluntad de hacerlo de manera voluntaria, ni de compartir las tecnologías y de tener una licencia libre o gratis. Tenemos que hacernos escuchar y que les duela para que cambien.
I can comment briefly. I
Yo
take the point. I think it's very
puedo
important.
comentar brevemente, sí, tomo el punto, esto es importante. Hay alguna resistencia a la acción. Esto tenemos que escalarlo. Esto no va a ser fácil. Yo pienso que en los Estados Unidos compartir tecnología se ha discutido muchísimo por fuera de la industria misma. El país es con una cantidad de incendios por tantos problemas que tenemos. Pensamos en cosas que no se han explorado cuando hablamos, por ejemplo, de restaurar el liderazgo de Norteamérica y enfrentar esta crisis una vez que llegue potencialmente un nuevo gobierno, poder resolver todo esto, pero esto no es como que, no creo que, yo creo, pues no quiero que pierda importancia la severidad o la gravedad de este problema. Y todos tenemos que cambiarlo. Habiendo dicho esto, yo creo que las personas tendrían más simpatías con estos problemas. La urgencia es actuar ya, que los países empiecen a actuar ya mismo. Eso es lo que tenemos que hacer.
Gracias, Joshua, por la intervención y la reflexión compartida. Podríamos tener la intervención de Madeleine.
Sí, muchas gracias. No sé si es mejor hablar en español o en inglés.
No hay problema. Cualquiera de los dos tenemos traducción simultánea.
Ok, muchas gracias. Tengo una pregunta para los ponentes, quienes quieran responder, quizás Lorena o Alvin, no sé, pero no sé si pueden dar una idea de en las Américas, en América Latina, ¿cuáles países verían que tienen marcos legales adecuados para enfrentar los retos que presenta COVID en cuanto a patentes? O sea, ¿cuántos países de la región tendrían más o menos avances importantes que han hecho para tener excepciones al acuerdo TRIPS, para permitir licencias obligatorias y cuántos serían realmente muy rezagados en este tema? Y entonces, para un posible programa de trabajo a nivel nacional, ¿qué serían los primeros pasos que tendrían que pedirse a los gobiernos de la región?
Gracias, Madeleine. Podríamos iniciar. Lorena, si quisieras iniciar.
Sí, por ahí responder un poco a Madeleine, no sé cuántos para decirte un número, pero analizar todos los que son miembros de la OMC han debido adoptar sus leyes de patentes entre los 90 y los principios de los 2000. Entonces, la protección está. Y el tema de las salvaguardas, bueno, tiene que estar, para poder ser usada, las licencias obligatorias tienen que estar dentro de la ley nacional para poder ser usadas, así como todas las otras que presentamos. En general, la mayoría de los países en la región tienen en sus leyes nacionales el uso de licencias obligatorias. Y tenemos algunos ejemplos, Brasil, Ecuador, bueno, la sociedad civil ha trabajado con mucho esfuerzo en Colombia para intentar una licencia obligatoria en su momento sobre caletra y ahora sobre un grupo de medicamentos para curar la hepatitis C. No ha sido tan fácil lograr la voluntad política de un gobierno, porque eso es lo que buscamos en el caso de las licencias obligatorias. No ha sido muy fácil porque, bueno, en todo ese, digamos, recorrido, por ejemplo, en Colombia hemos visto que hasta la Embajada de Estados Unidos presiona, se utiliza, la industria utiliza todas las formas de poder presionar con distintas represalias económicas en los países para que no hagan uso de licencias obligatorias. De todas maneras, decir que cuando se usa, por ejemplo, en el caso de Brasil, se logró un 60% de reducción del precio del medicamento que se trataba, en ese momento era el Lefavirenz. Así que se recomienda, y bueno, la sociedad civil que se nutra, digamos, de lo que dice su legislación, de que si es necesario también se propongan, como ahora se está proponiendo en Brasil, una nueva ley, licencias
Being proposed in Brazil a new law of automatic licenses that do not depend on that political will of the executive power. In Brazil, we have the role of pushing these topics forward and get an answer from the government. Peter has the same experience. Lorena, thank you. Would you like to add something to that specific question?
What Lorena just said about automatic licenses, I think is pretty important. Anywhere we can advance that politics is, of course, very useful. I mean, this is what the tools exist for, right? If not a pandemic, then when? So all countries really should just have an automatic licensing regime now, and the question should be one of what royalties are appropriate and what uses are appropriate and so on. There were a couple of questions in the chat that are probably worth bringing out here, which had to do with sort of the use of licenses, given that so much of vaccine production has to do with non-patent issues, like having confidential information, and how do we think about manufacturing all across the world when we expect China and India to pursue their own interests as well. I think that's really important. And I think, in a forum like this, we try and give our best answers, but I think what really matters is getting as much good thinking from the community as possible. I think the patent licensing contributes to the politics. It's politics first, right? It's if a government like the United States decides that it wants to do something, it can find all kinds of legal solutions and mobilize all kinds of powers and convene technology and so on. So I think, foremost, this how we create a demand that can't be ignored. That said, it's interesting to think about the tools that we would use. So the patents help toward, licensing helps toward that end, right? If countries are issuing licenses, it helps create the demand, and we can expand from there to different carrots and sticks that help divulge the know-how and ultimately provide technical assistance and lead to all of us trying to help each other how to make vaccines. Not every country in the world is probably going to be appropriate, in my opinion, for vaccine production, because there are real challenges now, and we shouldn't underestimate, I think, the challenges either of getting to scale and having the right technology in place and doing it quickly. But I think there is more capacity out there than is being used, and certainly governments can supply extra capacity. So hopefully if we can work on the politics of that, we will have more practical solutions for the manufacturing. It's our moonshot, right? For those for whom that reference means something.
Gracias, Peter. Veo acá en
Thank you, Peter. I see in our option for questions and answers the participation and even the narration of an experience in Colombia with respect to follow up on patents. I don't know, Oscar, if you have the possibility to use the audio to be able to share this experience with sound. I would appreciate it if we can use this just for the panel discussion.
Bueno, no sé si de pronto Oscar
I don't
Lizarazo.
know if Oscar Lizarazo, he's a teacher at the National University in Colombia and expert in this topic of patents and access to medication. Hello? Yes, he's there. Okay, Oscar, can you hear us? Yes, good morning, Angela. Thank you, everyone. I wanted to ask, I wanted to first thank everyone for their presentations and ask Lorena, in addition to the database of Médicos Sin Fronteras or Doctors Without Borders, what other mechanism is there to exchange possible oppositions or requests for patents to make the oppositions? I just had that question because in Colombia there are 5 patents already granted, and the contrast or the difference between Colombia and Argentina is that Colombia can follow the most, I think we have the most flexible ones. Argentina has the strictest ones, and ASEMFAR sued that guideline, but that process is slow. So since oppositions have certain opposition from the technical and legal standpoint, how can we make more opposition in South America, taking advantage of experiences like yours? I don't know if, in addition to the patent opposition database, you might have some other mechanism. We made some oppositions to Remdesivir, but many of them were granted in Colombia. We want to opt for an annulment option, I mean, to revoke that decision, but it's more difficult to do it in Colombia. I mean, I just wanted to mention this. We had an experience opposing to a patent of CRISPR-Cas. They already have some patents in Latin America granted. So that patent of CRISPR was granted to California, Berkeley, and we also organized another one. But I think it's about exchanging information as far as chemistry and pharmaceutical information because, and I had another short question, and it is, how can these receive, I mean, this important effort of Costa Rica receive more support? I mean, the patent pool, technology, and access pool. I think it's very interesting because, but it has not received as much support as you would want to. It would be desirable for it to receive much more support. Thank you very much.
Lorena.
Thank you, Oscar. Lorena? Yes, well, thank you very much, Oscar, for your question. Well, I have several answers. First of all, yes, the patent opposition database of Doctors Without Borders is a very important site and source for when we do the opposition work. And the different organizations, we're not so many of us, but there are a few around the world who work on opposition to patents, and we uploaded into this site all the result of our work. In Brazil, there's also a lot of capacity. They've been more so, they've been our teachers really in this subject of opposition to patents. So you find there lots of capacity and work on oppositions. I don't think there isn't another database, but what we can do is share our contacts and anyhow help you get into contact with the chemistry group. We have two chemical chemists. We work in an interdisciplinary team, and it's the chemists who are in charge of the most complicated and technical part in the analysis of requests, because I mean, you would seem to think that this is simple, and it is not. There are requests for patents that might have up to 130 reivindications and 900 or thousands of pages with the description of the technology that they are attempting to patent. So it's a technical and complex work. But yeah, I can offer this. I can help you get into contact with them and see what we can do, because in the case of Remdesivir, we've seen that most of the patents, more or less, they're the same, just with a few changes. And what the company does is they develop that request, and they present it or translate it according to the requirements, and they present almost the same ones around the world. So yeah, I can offer that. Thank you, Lorena. I will interrupt you now because we have 5 minutes left of discussion via this session. But before closing, I would like to read two questions out loud that I think could incentivate us to continue with our discussion and exchange of ideas through the Telegram session. The link can be shared later by our platform administrator. And the two questions left, which are very interesting, are the first one is by Jorge Maria de Bello. How can we make other governments join the effort for the request of proposals through India and Africa to the APIC Council? How can we organize ourselves as civil society worldwide so that we can use the medical technology? And the second one is Alberto Ferrari. Any other country in Latin America, did any of them accept the demands of the multinational companies of extending sovereignty immunity? I think these questions open a space for many more discussions and hopefully agreed to initiatives, you know, shared by Lorena. So with these two questions and this invitation for us to continue exchanging ideas and having discussions through the Telegram link, I will leave you with this. And this panel has been very enriching to explore possibilities. So I will start closing this first main panel of the week on intellectual property as far as public interest in COVID-19. For us at Misión Salud, it has been an honor to be here sharing with you, with the participants, and unquestionably, I think we've been able to achieve the purpose, which was to respond to the main question summoning us together this week. And it is, what are we going to do with the patents and the possible treatments and vaccines at the point of global emergency? As we were saying before, we are not only referring to pathological outcomes, but also social economic outcomes, which will affect or which affect a very large and important portion of our society. So I want to thank the panelists, the participants, and in brief, more or less in 5 minutes, we could be continuing our exchange of ideas in the other link. Thank you very much. So I allow each one of you panelists to say goodbye and say a few words.
Bueno, yo quería terminar agradeciendo.
To conclude by thanking everyone. Despite the pandemic, it wasn't possible to hold the Global Congress in Colombia, but I think it left a great initiative to do it this way, virtually, because these debates are very important, I think, at this point, to be able to hear each other and share the different ideas and have a clearer panorama, as well as empowering ourselves, because we need to realize that it is possible to have a world without patents once again. Thank you.
Un minuto, Peter.
1 minute, Peter and Alvin.
agradecer.
I want to give my thanks and gratitude for having been able to listen to the efforts everyone is trying to do in their own countries. And it's clear for us, and I say it honestly, that the pharmaceutical industry is not Mother Teresa. And the most important thing we need to do is guarantee access to medication for the population. And within this context, the only thing we need to do is be solidary to be able to deal with all these um, difficult situations of today. That would be like the path to follow, work on the WHO so that difference between one letter C to OMS can go to WHO for health for everyone. Thank you very much. Thank you, Alvin. Peter, I think you're able to give a few words of goodbye.
Y a todas, y estamos en
Thank you very much, everyone, and it was a pleasure. Thank you. Thank you.
Hasta luego. Muchas gracias a los tres.
Thank
Gracias.
you all.
Los invito al link de
I
Telegram.
invite you to the Telegram link.
El
It
intercambio
might be that the exchange can continue, so we'll see each other there.
Bárbaro.
Chao.
Bye.
Chao, querida. Chao.